Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Ali Khan Lalani and Christopher Wallis.
It's 5 o'clock in downtown San Francisco, January 25th. Welcome to The View on GU. Thank you so much for joining us, ladies and gentlemen. I'm Ali Khan Lalani, joined by my host, Christopher Wallis. It's day one of GU ASCO. Chris, how are you feeling, man?
Great, man. We got a day of prostate cancer in the books. We've got excitement all around, and I think we've had really great feedback and interest in this podcast. So hopefully the content we can put out starting today matches the excitement.
Yeah, I think it's great to thank everyone who's been out there sending us messages. I know both you and I were chatting about this off camera, just how much people have been excited and supportive. So we really want to thank everyone for that. And so let's kick off and do the rundown for day one. Prostate Day, as you said. We're going to formulate, I think, the first really part of our discussion around two major bins or buckets that we'll talk about. I think what we kind of took away was an approach for patients who are mCRPC, never had any other systemic treatment, and then for patients who have previously been treated for mCRPC, had a novel hormonal agent or an ARAT, what are options for them? So that's really kind of I think the takeaway for the first part of our conversation. So, Chris, let's set up what was called the, Abstract 19, the breakaway trial. Dr. Maha Hussain presented this essentially. I think the background really, as folks probably know, is we have had PARP inhibitors as really genomically directed therapy for patients who have really defined alterations and have been previously treated with prostate cancer medications. We've had more recently the 3 trials of combination treatments in terms of magnitude, Talapro, and Propel with putting an ARAT and a PARP inhibitor together. Chris, what did we really learn from Breakaway, and what's your really takeaway of this 3-arm trial?
Absolutely. So I think, we kicked off the day, first talk out of the books, and it's a big one, I think. We have to put it in context. Just like the 3 combination trials you discussed, this is a study that was designed a while ago. Mm-hmm. And this is the hardest thing I think about prostate cancer is the landscape moves so fast that by the time your study is accrued and read out, the landscape has moved on. So, this is a study designed in 2016, starts enrolling shortly thereafter. So we're not really in an intensified era pre-mCRPC there. So we don't have an mCRPC treatment intensification. We don't have mCSPC treatment intensification that's widely adopted. Charted's read out, Latitude is yet to read out in this kind of era. So it's important to understand that we're talking here about a first-line mCRPC trial, but we're also talking about first-line mCRPC in an era when this is a patient arriving there probably only having seen ADT through their, pre-treatment space, whether that be non-metastatic or metastatic. So I think that sort of lays the groundwork. And then the question really addresses one that I think certainly I had, and I think many of us had when we saw, Talapro 2, we saw Magnitude, we saw Propel come out, which is we're in the context of Profound, do we need to give these together or can we sequence them? And so this study is a phase 2. So it's a little bit on the smaller side, but it's a 3-arm study. We've got, upfront olaparib monotherapy, which was interesting because we haven't seen that before. We have upfront abiraterone, or we have the combination of the two. And the nice thing that addresses that sequential question is we have crossover. So in arms 1 and 2 that get monotherapy initially, when you fail, you can progress and switch over to the next line of therapy. And I think it's important to understand in the context of phase 2, we're not talking about OS results here, right? We're looking for PSA-driven endpoints, we're looking for response rates, and we're looking for some PFS data. And the takeaway that I have really is, it's remarkable they pulled this trial off. I think it's a real achievement. And I think it actually builds on and supports the data we've seen over the last couple of years with combination therapy and the other phase 3 trials, because that combination arm really did a fair bit better than the other 2 arms, even when you had crossover allowed. So there was no catching up with a crossover design. So that initial combination approach in arm 3 gave you such a head start that even when you crossed over, whether it was from Abi to olaparib, which is kind of a Profound style approach, or olaparib to abi, which is an approach that we haven't really adopted before, you couldn't make up the difference. And so you're 15 months or so behind on your first PFS event, and then you can only catch up maybe half of that or less.
Yeah, no, I think it's all good. I mean, BRCA largely selecting for BRCA1, 2, and ATM, and I think Dr. Hussain mentioned that we don't have the readouts of how each of these alterations performed, and that's understandable. It's a small study. I think it's part of future kind of evaluations, and I think the point you made is great, right? Crossover was allowed. I think that was ethical. But less than half of the patients, I think 8 in each arm that could cross over. So you had the, Abby arm, olaparib arm, and the combination arm. Those arms 1 and 2, only really 8 patients did. It tells you about once you progress, how unwell were they, what else was going on. And so the concept, as you said, right? I mean, do you catch up? I think if your patient can get effective combination options as a first line treatment for mCRPC, having been genomically selected, I think we have, a bunch of phase 3s and now this important trial to build the evidence to say, don't hold and wait.
I totally agree. And I think, when you put that in the context of the real world data that we see, it's really important. We see, clinical trials. We look at like Vision, and we're talking about 5th line therapy in these patients. That's a clinical trial reality, but it's not really a day-to-day reality. When you look at what goes on in our communities, most patients are lucky to see a 2nd line or maybe a 3rd line of therapy. We're not talking, numerous opportunities to just sequence and sequence and sequence. And so if we have, efficacious drugs, things that work, and particularly when it's mechanistically logical, an opportunity to give a guaranteed chance for that patient to get a minimum of 2 lines of therapy, I think is a great opportunity for these patients. Who may or may not be able to get it if you're trying to sequence it out. They may never see that next drug.
Yeah, and lots of us, as we care for these patients, are going to be really shepherding and I think responsible for how many agents they can get. So what would be kind of your takeaway to, the urology or uro-oncology community that sees these patients? Questions have been discussed about first line mCRPC, how to get genetic testing or genomic testing. Let's assume that's part of the game here. What would be your kind of takeaway based on what you've seen and your thoughts on not catching up by waiting on treatments?
Totally. I mean, I think this is prefaced on the notion that we ought to be intensifying sooner, right? So these patients maybe shouldn't be existing in our clinics, but we know they do. So if you've got a patient who's been only on ADT up until they hit first line mCRPC, number one, that's a bit of a trigger or red flag that they missed a chance to intensify earlier. So even more so, let's take the opportunity and do a little bit of catching up, get them a couple of lines of therapy kind of as soon as we can. And so to me, these are patients, if you are a bold urologist, you may want to try and take on PARPs. I don't know that I'm that bold. I've got enough of my surgical complications to manage that I don't know if I want to take on the marrow suppression complications as well. And so to me, this is a patient that needs to see a med onc. It's got to get in there and have a conversation in much the way that we have the triplet conversation in MCSPC. These are patients who multiple lines of therapy in the same setting are potentially life prolonging. And so that needs that multi-D consultation.
Yeah, no, and I think how centers roll that out, whether it's jurisdictions, provinces, to get this testing, as you say, cooking as much as possible, because how will you catch these patients? I think it's important. And a comment was made also from the Q&A, which I feel like you can learn a lot from when folks get to the mic and ask a question. But there was a comment saying, how do we interpret this given what we perceive, which is so much treatment for MCSPC now? Do we reconduct trials like this? And I think one of the takeaways is that, look, it's already moving fast. We have PARP inhibitor driven, studies in MCSPC ongoing and cooking. But I love the theme and the way you laid it out, and really what we need to do to shepherd these patients, right? However it's done, it might look differently for each center, but testing and then appropriate treatment. I think it is a muscle memory change, right, for what we do. So it is a bit about change management in each of our centers. So I love that summary, and that was an important, as you said, first phase 2, not a registration trial, but added the weight of evidence.
Absolutely. And so, I think as we try and build here, we're already kind of alluding to this, and I think it leads us into the next presentation that we saw time-wise in the conference. And I think the next thing we want to talk about, which is CONTACT-2. And the notion we're thinking here is that more mechanisms of action are probably better, right? We want to increase the number of tools in our armamentarium. And so we've been trying this in prostate for a long time.
Mm-hmm.
IO is everywhere in oncology, and we've been trying to get checkpoint inhibitors and immunotherapy into advanced prostate cancer for at least 5 years, typically in combinations with established prostate cancer drugs, right? So we're adding to Enza, we're adding to Dosi. And I think what's really interesting in Contact 2, and I'm interested in your take on this, is we've essentially taken two drug categories that don't have an established role in prostate cancer management, and we've made that the investigational arm in this new study. And if this pans out, it offers us two new mechanisms of action in prostate, which is, I think, a really exciting possibility. So I'm interested in your takeaway on Neeraj Agarwal's talk.
Yeah, this was really anticipated. I mean, we had Contact 2 at our center at the Juravinsky. We recruited to this, and I think at the time, as you said, we got to set it up that this was a trial, designed some time ago, already reading out. And it was in an era where for mCRPC, I think there was some thought that for patients who progressed on an NHA or ARAT, that a control arm of the alternate ARAT was fair game. I mean, Profound did this. Other trials have had that. And so this was no different, right? I think the key thing for reframing folks who maybe aren't aware, this is a mCRPC trial. Patients progressed on an NHA. And importantly, they had measurable disease, which means extrapelvic soft tissue metastasis, either visceral or lymph node, which again isn't a super common patient population. And in fact, it led to a lot of screen fails in this trial, is trying to ensure did they have this, and really the ethics around these patients being randomized to an alternate NHA, but it was acceptable at the time. So that was the control arm randomized 1-to-1 against cabozantinib, a VEGF TKI, which we know well in the kidney cancer game, studied in prostate cancer previously, and atezolizumab as the PD-L1 immunotherapy. And just even before we look at the outcomes, I mean, I was curious because we had Comet 1 in mCRPC, a trial that showed cabozantinib had activity against prednisone, PFS of about 5 to 6 months, and survival that wasn't really that different from prednisone. So that was the context of what we had here. For this patient, trial. I think what I was curious to see is how many patients are entering the control arm, having had an NHA in MCSP or MCSPC or NMCRPC setting, and this was really 1/4 of the patients. 3/4 were all entering off of having an NHA already for mCRPC, already having, visceral disease potentially, 1/4 of whom had liver metastasis. And that's really the context of the study. So to see that, in the end, we saw a PFS of around 6.3 months on the intervention arm, 4.2 months in the control arm with a hazard ratio of 0.65, technically a positive study. This did have a co-primary endpoint of overall survival, and we found that the control arm performed around 14 months. The intervention arm really improved that to 16.7. Now it's early, still pending a lot more events, but that was really the top line data. I think the comments made during the presentation was that for patients with liver metastasis, so again, 1 in 4 on this trial, the control arm performed at around 2 months for RPFS and around 6 months for the interventional arm. Disease control rate favored the combination. So, I think the takeaway was nicely summarized. I think Kim Chi did a great discussion to kind of lay what this trial adds. And I think it is nice to see a TKI and an IO, but I think it is fair, as you said, matching IOs against effective prostate cancer treatments. And cabozantinib on its own, we can debate about whether that's really a standard of care life prolonging option because it has not been shown yet. We have not seen IO add much more. I think it would have been hard to design this trial with cabozantinib alone, and I think that's understandable. But I think, really for me, it's the big picture of, which patient should be getting that NHA again.
Mm-hmm.
We were talking about this off camera as well, that, really the patient that has been progressing on an NHA or ARAT, who has maybe minimal symptoms, we're catching biochemical progression with a rising PSA, maybe on staging, finding a few areas of change. These might be patients where it's fair to discuss with them. Maybe they're ineligible for other options to give that switch ARAT, with the caveats that if you are switching to a tool that they've basically seen, I think you want to keep a close eye, follow them closely and really restage them closely. But I think for patients who have, visceral disease, measurable disease, known to have liver metastasis and progressing on NHA, their body has changed. They have progressive cancer. They've experienced the NHA. I think really the field in the routine, clinical care for these patients would probably tip in favor of an alternate option.
Totally. And I think the other thing that, I always struggle a bit with these trials is we talk about NHA switch as if it's one thing. And in my mind, Abi to Enza is not the same as Enza to Abi. When you think even mechanistically, and certainly Kimchi's data plays this out, it's a more reasonable maneuver in my mind to go from Abi to Enza as a switch and expect some good to come of it. But to go from Enza and try and think that you're going to, switch them over to Abi and get some benefit. And so we treat it as one, and the studies are designed as if it's the same thing. But I think there is like a little bit of nuance there in terms of how we think about this.
I totally agree. I think that drills down into what is this switch and what is the agents. And I think, I've tried to describe which patient I think should get it. And then, the other thinking is that, well, what about chemotherapy in these patients? Would that have been a better control arm? I think that's fair. But if you look at least on this top line data, we have, 20% of these patients who are progressing on an NHA and somehow got an NHA again, 20% of these patients also got chemotherapy. So you almost wondered, those patients really should have gotten chemotherapy in my mind, because again, there's visceral disease here. And if somehow they progressed on a second NHA, their body changes, they have more, ARAT-related side effects and are still able to get chemo, to me, I think they really, from an opportunity cost perspective, probably should have had it up front. So I think, I appreciate how Kim kind of laid out that with all the tools we have that are life prolonging, for these patients, by definition, needing to have extrapelvic disease, I think there's other options for them. And of course, if your patient is ineligible and understands the risk, this might be something to think about, because I agree that Cabo and Atezo giving an RPFS of 6 months on the liver metastasis side is certainly noteworthy. And I think really what's going to be cool from this study is when we get the biomarkers that they've had, when we try and understand the patients that did well, is there a blood or a tissue finding that can guide? And I think there's room for that. I mean, this is the first readout, and I think there's more to come. But 1% of patients in this trial got lutetium. Clearly in the real world, that's going to expand over time globally, we hope, with more jurisdiction. So the real type of patient who would be eligible for this study should be having more other drugs seen prior. So, I think it was a really highly anticipated study. I think it's very, very important that if your patient is progressing on a typical ARAT, think carefully about, should I be going back to a similar mechanism of action, an alternate NHA? I think to me that's an exception. I think the rule, especially with visceral and extrapelvic soft tissue diseases, look at another type of action insofar as the patient is eligible and fair game for all of them. So that was really my takeaway on that abstract, and I think it created lots of discussion. But
totally,
those were kind of the two, I think, heavy hitting orals from the morning session. But there was obviously more and a full day of prostate. What was your takeaway from anything exciting in the rest of the orals from the morning today?
Totally. So we saw a couple of talks in the localized space. So, update on the French RCT, but treatment intensification with higher dose rates for radiotherapy, and you get some more bang from your buck. But to me, as a practicing urologist, I thought Formula 509 update was really interesting. And so this is a study predicated in the salvage space. So these patients have all had radical prostatectomy, and now we're trying to look at how we best salvage them at the time of biochemical recurrence. And so Paul Nguyen actually presented the oncologic outcomes of this trial at this meeting last year. And we saw some benefit, although, it's all about how you choose to interpret the trial, I suppose. This was technically a negative study at the top level readout with a real indication that in the patients who have a high pre-salvage radiation PSA, and by high we mean like 0.5, so it's a little bit on the late end of salvage radiation, that you get benefit from treatment intensification. So what do we mean by treatment intensification? So when we look at the context, you could give salvage radiation with just the radiation alone. Now, based on Shipley's data and others, certainly concomitant ADT, typically in the 6-month window, is pretty standard. And then, for the patients you're worried about, like every other disease space in prostate cancer, now we're trying to do more, right? And there's kind of two ways you can do more. You can either give more intense therapy, or you can give the same therapy for longer. So Formula 509 looked at adding to 6 months of ADT, apalutamide and abiraterone, or in the control arm, adding some bicalutamide for some, old school combined androgen blockade. And I think there's important takeaways. So we saw last year's data that, again, in that higher risk subset, higher pre-salvage radiation PSAs, that additional more intense ADT can give you oncologic benefits. So MFS in this study. But what we saw presented today by Karen Hoffman is the patient-related quality of life data. And I think, OS is everybody's be-all and end-all. But in the localized prostate cancer space, we really, I think, have to reframe our discussions a little bit. Prostate cancer-related mortality in MCRPC is the norm, and you balance. Maybe people are going to die of other things. Whereas in localized prostate cancer, it is by far the exception, right? So we should expect that most of these patients are not going to die of their prostate cancer. And so while oncologic endpoints are really important, and they're always important, the patient survivorship experience and what that actually looks like for patients, I think, is really, really critical, and something that probably should be forefront in our minds making these decisions. So the question here is, adding, in this case, 2 ARATs, two mechanisms of action. What does that cost the patient? And the answer, surprisingly, is not that much. And so we see quality of life deficits in both arms. In the active arm with ADT, ABI, and APA, and also in the control arm with ADT and bicalutamide, and they both suffer in the short term. So when you go from baseline to 6 months, there's hormonal effects, there's fatigue-related effects, there's some sexual toxicity. But by a year, so that's 6 months off of therapy, much of that's rebounded, and they're both back up pretty close to their baseline, and there's not differences between the groups. So by giving that additional intensified therapy, we're not actually costing much more than just our old school ADT, and we're maybe getting some additional oncologic bang for the buck. Just from a sexual toxicity side of things, it's worth noting that these are all post-surgery patients. For the most part, they were bad actors to begin with, so they didn't get much nerve sparing, so they didn't have much to work with. So only like 20% of these men really had erections before they went on any of these therapies, which does raise that question of, there's a floor effect. If everybody's so low, it's hard to find differences between the groups.
Right.
But I think that's valid for patient counseling. And so we need to put this study in the context of another study, and I alluded to it before, and that's Radicals HD. And so the alternative to giving more intense therapy maybe is just to give longer therapy. So Radicals asked the question, what about 2 years of just standard ADT as compared to 6 months? And that showed some benefit for the longer duration compared to the shorter duration. And it's an unanswered question currently if we can give shorter, more intense therapy as compared to longer, less intense therapy. And so Karen Hoffman, again, who presented today, is co-PI. She's a good friend of mine on what they call the Prostate IQ study. It's looking to activate this spring. So I don't know if we're going to be able to get sites near us, but it's going to answer the question. In this case, is intensified therapy with ADT and APA. They're dropping the ABI out of it because from a variety of studies, we've seen that you don't really need to do it twice. All you add is toxicity and not really efficacy. But does that 6 months of intensified therapy give you as much or more bang for your buck than a longer duration of just conventional ADT, with the potential benefit that getting off therapy sooner may actually give quality of life benefits to these patients? So, I think there's a lot of moving parts in this disease space, and we're certainly seeing ARATs migrate earlier and earlier into our treatment paradigms. And so, we're looking at, the BCR space, and this is a step before Embark even. They haven't exhausted their local pelvic treatment, and we're already applying it. So I think, even more rationale for those who exist in this space, which is really, urologists and radiation oncologists, to either be comfortable writing ARSI scripts and understanding the indications and toxicity management and monitoring that these patients need, or again, broadening, what we mean by multidisciplinary care. We're not just talking the metastatic patients here. We're moving earlier and earlier into localized disease, and that needs that multidisciplinary involvement and an understanding of how to give systemic therapy.
Yeah, I mean, so much, and I agree with everything you've said. And I think even beyond the outcome data, I think it dovetails nicely into, how are our centers or jurisdictions prepared for earlier treatment? But then even once you intervene and describe these treatments for patients, I think what we're seeing, and as you've mentioned, this longer term follow-up for these patients who now have many years, either on or post therapy, that quality of life, how they're going to feel and function after treatment. I think when we see more and more of that follow-up, I'll be keeping a close eye, because again, we're all going to, these patients are all going to pass through all of our hands at some point with how we deal with them. And so knowing how they feel and function on prior treatments, even if it's curtailed or been intermittent or was, kind of time defined, the activities of rechallenges of drugs and, how patients live and experience thereafter, I think is so critical. So, top line data is important, but that quality of life long term is going to be critical as well. So I love how you summarize that. I mean, I think for me, one comment just was, we're about to wrap this first day summary, and time is flying. I mean, I feel like we could talk for an hour here, but we won't. I really like the opening. This is 20 years of ASCO GU. You and I are not at the point where we would have been at the first one, although I did see a lot of people who had the 20-year label on their lanyard, so I know they've seen the first of GU ASCO. But one thing, Eric Small mentioned is, it was initially built as a prostate meeting, and then they made the decision to say, we need to have all of our GU cancers involved, and we need to have all the people at the table. So having a meeting that now has many international involvement, I think Canada's clearly number 2 on the list. They showed who attends these meetings. But, their vision of having a multidisciplinary meeting, and then, I kind of smiled to see that, where we're at launching a multidisciplinary podcast, in a forum and a modality that wasn't available to them 20 years ago, but now we're here talking about the importance of multi-D care. It's just come really full circle for our origin story as well. So I smiled when I saw that this morning. And that was really, I think, interesting to me. But, I would encourage folks to, obviously, if they're interested, there's lots that happened today. I'll just give one plug for a session I found enjoyable, maybe not without having a crystallized answer, is a scenario floated about patients who have started on triplet therapy and they progress. And the question was really kind of what's next. And we had great talks around this. I think one of the big takeaways for the community is that if you are proceeding with treatment in so-called triplet fashion, ADT, an ARAT of choice that's approved, and chemotherapy, docetaxel for 6 cycles, I think the next option is really going to depend, as we've always seen, but that time to the patient progressing. And I think we are all seeing in our clinics, unfortunately, some patients getting triplet, we feel is full kitchen sink approach, but are unfortunately progressing within 2 years, 18 months, and sometimes within 1 year. And we've kind of known that biology of being, challenging. But I think there's going to be such a divergence of the patient population we have in our clinic who got years on that triplet approach versus 12 months. And I think the panel really tried to highlight, have they been genomically tested? Is lutetium available? If they are progressing within that 12 to 18 months, thinking about an alternate form of therapy. I think that's really the importance to keep in mind. So it's not just the decision you make at intervention of triplet, but understanding that biology. Will they need a rebiopsy? This is where ctDNA could help show what they acquired for alterations, because we know the minute you start an ARAT, there's data showing within the first 3 or 6 months you're acquiring alterations. It may not manifest yet, but the body is acquiring that. And so, to me, that was a takeaway session. But it was a great day one.
Absolutely. We've, come out of the gates hard, I think. And I think we've got lots more, obviously, to look forward to. So I want to thank everyone who's joined us today. I really appreciate you tuning in, and hope something of what we've discussed has been of interest and hopefully helpful for you. Please like, review, subscribe, and leave us your feedback so that we can give you what you're looking for and best serve the needs of this community. I look forward to next episode. Tomorrow, we're going to be hard at it with the urothelial sessions. We've got some really exciting data coming. We've got Ambassador being presented. We've got fantastic data on Saturday looking at OS data in adjuvant kidney. I think this is two great examples where we really need multidisciplinary care. Absolutely. These are surgical patients needing systemic therapy. And I think it just really highlights that evolution of what we mean by GU cancer care and the focus on the meeting really in providing that multidisciplinary approach. So on behalf of my host, Ali Khan Lalani and Chris Wallis, and thank you so much for joining us on the VU and GU.